My name is Katharine Kolcaba, and here's a presentation about myself and my theory of comfort. Here's some information about me. I was born in Cleveland, Ohio in 1944. I earned my nursing diploma from St. Luke's Hospital School of Nursing in 1965, and then graduated from the Francis Payne Bolton School of Nursing at Case Western Reserve University in 1987. I earned my PhD in nursing in 1977 and received a certificate of authority as a clinical nursing specialist. I have an education specialty in gerontology, end-of-life and long-term care interventions, comfort studies, instrument development, nursing theory, and nursing research. I developed the comfort theory in the 1990s. The theory of comfort is a middle-range nursing theory. Middle-range theories are more concrete and narrower than grand theories. They are made up of a limited number of concepts and propositions that are written at a relatively concrete and specific level. There are two dimensions of this theory. The first dimension consists of three states: relief, ease, and transcendence. Relief is defined as the experience of having had a specific need met. Ease is defined as a state of calm or contentment. Transcendence is described as a state of comfort in which patients are able to rise above their challenges. The second dimension, the context in which the comfort occurs. The first component is the physical component pertaining to bodily sensations. The second component is psychospiritual, which pertains to the mental awareness of self, including esteem, sexuality, meaning in one's life, and relationship to a higher being. The social context, which pertains to interpersonal, family, and cultural relationships. Also included under social comfort are the financial and interpersonal aspects of social life. A little bit more about the theory. In the model, nursing is described as the process of assessing the patient's comfort needs, developing and implementing appropriate nursing care plans, and evaluating the patient's comfort after the care plans have been carried out. Nursing includes the intentional assessment of comfort needs, the design of comfort measures to address those needs, and the reassessment of comfort levels after implementation. Assessment can be objective, such as the observation of wound healing, or subjective, such as asking the patient if he or she is comfortable. The nursing paradigm has four components: nursing, person, environment, and health. The person, or humans, are holistic beings, unique, dynamic, sentient, and multidimensional, capable of abstract reasoning, creativity, aesthetic appreciation, and self-responsibility. The comfort theory looks at humans and patients holistically, and deserving of receiving quality care that provides comfort to them. In the environmental component, these are dimensions that may affect health, which include physical, psychosocial, cultural, historical, and developmental processes, as well as the political and economic aspects of the social world. Nurses who use the comfort theory provide a comfortable environment to the patient that promotes healing and desire to improve health. The health component is a dynamic process, the synthesis of wellness and illness, and is defined by the perception of the client across the lifespan. The comfort theory provides quality mental health, part of the holistic care model. Finally, nursing, the final component, is an academic discipline and a practice profession. Human caring as the moral ideal of nursing is the central focus of the professional practice. Use of the comfort theory is completely in line with the concept of human caring as the moral ideal of nursing. Providing comfort to patients is one important way to show a sense of caring. Application of the comfort theory to research. The nursing research study of interest was application of Kolcaba's comfort theory to the management of a patient with hepatocellular carcinoma. The patient of interest in this study was Mr. M., a 49-year-old male patient with terminal hepatocellular carcinoma. In his most recent hospitalization, he presented to the emergency department for sudden onset of dyspnea and rest. He experienced worsening of abdominal ascites, jaundice, bilateral lower limbs edema, and was unable to ambulate. The chest X-ray showed bilateral pleural effusion with atelectasis in his left lung base, while his abdominal X-ray showed centralization of bowel loops related to ascites. The nursing interventions in the research study revolved around Kolcaba's comfort theory and consisted of interventions such as encouraging verbalization of pain and emotional support, encouraging verbalization of anxieties, concerns, and fears, and helping him to identify anxiety-promoting factors and ways to decrease anxiety. Evaluation. The patient reported an increase in pain management, decreased anxiety, and increased ability to cope with stressors. His physical condition improved, and he was able to be discharged in stable condition. Case study. Here's the scenario. A patient was admitted to subacute rehab following a right total knee replacement. She was concerned about infection of the incision site because of the pain and swelling she was experiencing. The woman shared of a recent event where a friend of hers had the same surgery and passed away from infection and sepsis. The patient was fearful and anxious about the same thing happening to her during her recovery. Interventions. I assessed the patient's knee for any increased drainage or edema. The patient had a normal temperature of 98.9. Her CBC showed a white blood cell within normal limits. I explained to the patient that based off of my nursing assessment, she was not experiencing any signs of infection. I listened to all of her concerns and validated her feelings of fear and anxiety. I encouraged her to talk to me about them whenever she felt overwhelmed or was concerned with something that might be wrong. The outcome was the patient visually appeared much less anxious and concerned, and she stated that she was very grateful that I had taken time to address her concerns. The patient went on to have a normal recovery and was able to go home without any complications within 7 days of admission. It must never be lost sight of what observation is for. It is not for the sake of piling up miscellaneous information or curious fact, but for the sake of saving lives and increasing health and comfort. Here are the references. Thanks for watching.